Hello everybody, my name is Mateja Zidarič and I'm a medical doctor in University Medical Center Maribor, Slovenia, in Department of Dermatology. Today I will present to you a clinical case report of dermatological adverse reaction during anti-tumor necrosis factor alpha therapy in patients with psoriatic arthritis. Psoriatic arthritis is an inflammatory disease with multiple musculoskeletal and dermatological manifestations. It occurs in up to 30% of patients with psoriasis and plays a significant role in quality of life of those who are afflicted. More than 50% patients with psoriatic arthritis exhibit progressive erosive arthritis that is often associated with functional impairment. Early diagnosis is important to prevent long-term functional disability and to ensure optimal management of arthritis and other comorbidities. The diagnosis is clinical and involves heterogeneous conditions with musculoskeletal involvement such as arthritis, enthesitis, dactylitis, axial involvement, as well as skin and nail manifestations. Patients with psoriasis and psoriatic arthritis have increased levels of T cells such as interleukin, interferon, and tumor necrosis factor. Together, these cytokines drive skin and joint inflammation. Several treatment options exist for psoriatic arthritis, for example, non-steroidal anti-inflammatory drugs, then methotrexate, cyclosporin, azathioprine, which all require diligent monitoring by the physician. The era of targeted biological drugs has transformed the treatment options for these diseases. One of the most successful treatments has been the use of anti-tumor necrosis factor alpha, adalimumab. Tumor necrosis factor alpha is a pro-inflammatory cytokine with multiple roles in the stimulation and regulation of the immune system. The mechanism of action is based on both the neutralizing of tumor necrosis factor alpha bioactivity and the induction of apoptosis of tumor necrosis factor expressing cells. It is usually used together with other systemic treatment such as methotrexate or phototherapy because the combination therapy increases the better outcome. So we presented a case report of a 43-year-old Caucasian woman that had long-lasting human leukocyte antigen B27 negative psoriatic arthritis with minimal manifestations of nail and scalp psoriasis. For 2 years, she was treated with adalimumab and for 3 years with methotrexate and folic acid. The treatment was successful with very good clinical result on joint inflammation. After 2 years, she developed adverse reaction that prevented ongoing use of this therapy. She presented with generalized reaction after 2 years of subcutaneous injections with adalimumab with combination of methotrexate and folic acid. The patient developed disseminated erythematosquamose and pustular eruptions on her face, trunk, back and lower extremities with pustular palmoplantar lesions, followed by desquamation of the skin on these areas. The therapy with adalimumab was discontinued. The anamnesis for high fever, recent viral infections, contact dermatitis, new medication or angioedema was negative. The histopathologic examination of skin biopsy confirmed inflammatory changes in favor of drug-induced dermatitis with acute interface reaction and interstitial infiltrate containing eosinophils and some neutrophils, accompanied by a differential diagnosis of psoriasiform dermatitis. There were no abnormal findings in blood and urine laboratory evaluations, including negative titer of anti-nuclear antibodies and negative titer of complement C3 and C4. Swab tests for pathogens were negative. Viral infections for herpes simplex virus 1 and 2 and varicella zoster were also excluded. Treatment was initiated with systemic corticosteroids, systemic calcipotriol, and systemic antihistamines due to severe pruritus. Topically, the combination of corticosteroids and antibiotics were administered. After a few days, clinical picture rapidly improved. So in this clinical case, we report a severe cutaneous reaction to adalimumab in a patient with psoriatic arthritis that required termination of therapy. Through other case reports, we also found some resembling clinical manifestations of cutaneous side effects like psoriasiform eruptions during anti-tumor necrosis factor agents. Although our patient was receiving concomitant immunomodulatory therapy, the medication was not discontinued when the reaction developed, and no other potential pathogenetic mechanisms were identified. Therefore, we believe the reaction was most likely attributable to adalimumab. If the psoriatic arthritis or the psoriasis would worsen again due to stopped biologic therapy, we would recommend the biologic agent from another pharmacological group, for example, interleukin-17 inhibitor or interleukin-23 inhibitor, which both have favorable effect on both clinical manifestations. I would like to thank all of you for listening and wish you a nice day.